thiamine. All right, so look at this particular figure, which is almost same as what I have drawn earlier. If you follow it, glucose 6-phosphate dehydrogenase deficiency. Follow the figure. Start from glucose. Okay, so glucose undergoing glycolysis initially. So you got this glucose 6-phosphate once it gets in. And that glucose 6-phosphate, it can go into glycolysis, which we have studied, and making 2-lactate because you are looking at RBC. This is a red blood cell. See, there's a biconcave shape and erythrocyte written here. So it's an anaerobic glycolysis, 1 glucose to 2-lactate. If it goes towards glycolysis, as you all know, glucose 6-phosphate has got other alternate ways to go. And one of that is it can go into pentose phosphate pathway through this glucose 6-phosphate dehydrogenase enzyme. And with that, you're going to get 6-phosphogluconate. That's the oxidative phase of pentose phosphate pathway. And one of the outcome of that particular reaction is NADPH plus H plus. And that NADPH plus, it is used to convert GSSG into GSH. And that is done by glutathione reductase. And that GSH, which is available now, it will be neutralizing hydrogen peroxide into water molecule done by glutathione peroxidase. And that's how you're going to neutralize hydrogen peroxide, which is a reactive oxygen species. That is what is shown here. What if your G6PD is deficient? So again, going back to what we have learned earlier. So we are going to block this. G6PD is deficient. That means there will be decreased NADPH, leading to decreased glutathione reductase enzyme activity and leading to increase in GSSG and decrease in GSH. When the GSH decreases, that means glutathione peroxidase activity decreases. That means there will be buildup of hydrogen peroxide. And this hydrogen peroxide will lead to increase in hydroxyl radical. And that hydroxyl radical causes hemolysis. And hemolysis will lead to anemia, which is not written here. So hemolysis leading to anemia, and that's why it is a hemolytic anemia. And also it leads to increase in bilirubin. That leads to jaundice. Okay, what type of bilirubin and all that you will study later in block 3. Direct bilirubin, indirect bilirubin, there are different kinds of bilirubin. There you will differentiate where is the issue, depending on which type of bilirubin is elevated. Anyway, so hemolysis leading to increase in bilirubin and anemia. And also remember, whenever there is increase in bilirubin, then you may find bilirubin stones in the gallbladder. That is called calcium bilirubinate stones in the gallbladder. Okay, so I'll write that here. This is just applicable to all hemolytic anemias. Calcium increase in calcium bilirubinate, bilirubinate stones, calcium bilirubinate stones in the gallbladder stones. You may see these stones in the gallbladder, kind of greenish yellowish kind of stones, which is calcium bilirubinate stones in the gallbladder because of hemolytic anemia. Okay, and then because there is increase in that hydrogen peroxide leading to generation of reactive oxygen species, your hemoglobin can be oxidized. See down here they are written oxyhemoglobin into methemoglobin, and that is making Heinz bodies. So there is a formation of Heinz bodies, which are precipitated hemoglobin molecules. Okay. Now, this hydrogen peroxide, the levels of hydrogen peroxide may increase in our cells due to certain events, certain biochemical mechanisms or biochemical processes that can happen depending on any external agents that we are taking into our body, or if we get into any infection. So in response to that, there is generation of hydrogen peroxide. Just to, that's a process. That's how the chemical process goes. So those things are briefly mentioned down here. As you see, oxidant stress. Whenever there is an oxidative stress, whenever there is a stress as such, there is an increase in free radicals in our body, and we should have sufficient GSH to fight against them. That means we should have pentose phosphate pathway running properly. So oxidant stress, it can be because of infections, or it can be certain drugs, or it can be consumption of beans, fava beans. Because when these fava beans are undergoing digestion process, and later the products of these fava beans, as such, they will lead to increase in hydrogen peroxide, thereby increase in reactive oxygen species. That means there will be necessity of GSH to take care of them. So whenever we go through infection, whenever you take drugs and chemicals, right, or whenever we consume such foods which will increase reactive oxygen species like hydrogen peroxide, hydroxyl radical, all that, we need to have sufficient GSH in our cells. Thereby, our cells are protected. What if your GSH levels are down, but you are taking all this, or you are going through all these oxidant stress events? Then they will take an upper hand and start damaging the cells. That's what happens in these patients, in G6PD deficiency patients. So, before we go for break, I'll ask you a question. Without thinking twice, if you take any medication, you got a little bit headache, you took Tylenol, you had a little bit that, you took this, some people, they just like, without caring, they just take medication. What happens when the medicine goes into our body? Which is the organ that has to take care of that medicine, detoxifying that medicine? It is the liver, cytochrome P450. Cytochrome P450 needs what? Pentose phosphate pathway, NADPH. NADPH, why? So, in order to detoxify. And also remember, the drug will lead to increase in free radical generation. That means you need to have sufficient GSH, antioxidant. So, if you don't have sufficient antioxidant, or if your pentose phosphate pathway is down, then there will be issue with the liver detoxification process. It will have a lot of effect on our liver. That is why medicine has to be taken only when there is absolute necessity, not just like little bit headache, you take Tylenol. You should not. Just take rest. It will go. Maybe that headache is because of a lot of screen time and all that, right? Or you didn't have good sleep. You have a headache. Sleep. Next day you're fine. No Tylenol. It's not the answer. Okay. So, like that. And there are a lot of, coloring agents we consume. Coloring is all these food colored so that it looks attractive in the market, supermarket shelves, lot of colorful things. Why? Because to attract customers. Pink, red, all that, your favorite colors, you go and grab it. And color is a food additive, and it doesn't have any nutritive value, no nutrition. So there will be a lot of pressure on the liver to get rid of it. That means cytochrome P450 works over time. So next time when you see color other than vegetables, other than veggie colors, all the artificial colors, don't take it. Go for colorless. If you really want to have that sweet, choose the one which doesn't have color. At least you are avoiding detoxification, putting pressure on the liver. Color things, just remember, it is going to put pressure on the liver. Okay. So that's all for now. When you come back, I will go into details of G6PD deficiency. Thank you. Okay. Now let me take you into little more details on glucose 6-phosphate dehydrogenase deficiency, how to identify this in the case stem. So G6PD deficiency is the most common cause for hemolytic anemia. The most common cause for hemolytic anemia is G6PD deficiency. Compare that with pyruvate kinase deficiency. Pyruvate kinase deficiency is the second most common cause for hemolytic anemia among all enzyme deficiencies. The first most common is G6PD. Anyway, that is not really that important. Coming to the first important point here with G6PD deficiency is it is X-linked recessive inherited disorder. X-linked recessive inheritance pattern. That means when you look at the case stem, it will begin with so and so, whatever the year, male. Look for that. If the case stem says, say, 22-year-old woman, then you should not think about G6PD deficiency, maybe pyruvate kinase deficiency. If there is a hemolytic anemia, but it's a woman, then rule out G6PD there. So this is X-linked condition. And then it is commonly seen in African, Middle East, and South Asian descent. There is a reason for why in Africa, Middle East, and South Asia, G6PD deficiency is seen, and also in Mediterranean region, Mediterranean region. One of the connection here is G6PD deficiency, which is an X-linked condition. It is seen commonly in areas wherever there is a malaria is endemic. Malaria endemicity. Similar condition, like similar to G6PD, where there is a hemolysis going on in another disease called sickle cell anemia. There is a disorder called sickle cell anemia. Some of you might know. Sickle cell anemia is also common in areas where malaria is endemic. The reason for this is malarial parasite, it will thrive in red blood cells. And malarial parasite uses red blood cell to make its progeny, means to bring up more and more malarial parasite for reproduction process. It uses red blood cells as one of the cell in the body. As long as red blood cell is surviving, it is good place for malarial parasite to thrive there. So in these conditions, in G6PD deficiency in sickle cell anemia, what happens to the overall lifetime of red blood cell? Decreases drastically. Red blood cell is breaking open because membrane permeability here. In sickle cell anemia, because it's a sickle shape, abnormal shape, spleen is going to kill it. So in these conditions, red blood cell destruction is happening faster than normal. That's why malarial parasite won't get sufficient time to make its progeny at higher levels. That is why severity of malaria decreases in disorders where red blood cells are affected. As a survival mechanism over a period of time as a population genetics. So there are certain conditions which are evolved, genetic disorders which are evolved to increase the lifespan of that person by protecting them from severe conditions or lethal conditions like malaria. Malaria is a lethal condition. Person may die with malaria, but person may not die with G6PD deficiency and sickle cell anemia. It's not lethal. So it is good to have milder conditions while protecting yourself from the bigger disorders. That is why as a population genetics, this type of conditions are commonly seen wherever malaria is endemic, just to have a protection. Okay, and that is one of the reason why in Africa, Middle East, South Asia, see there are more G6PD deficiency because of malaria. Anyway, now because this condition is G6PD deficiency, not complete absence. Deficiency means what? Maybe instead of 100%, 50% enzymes are present, 50% not working, something like that, right? Deficiency. So that means there will be decrease in NADPH, not absence of NADPH. It is just decrease of NADPH. Decrease of NADPH means what? Decrease in GSH, not absence of GSH, right? It is decrease. That means it is still there. There is some amount of GSH which is still there. Only thing, it is not like normal. So these patients, G6PD deficiency patients, whatever the NADPH and GSH they still have, despite of deficiency, they still have NADPH, they still have GSH. Are you agree? You agree? Because it is just deficiency, not absolute absence. So whatever little GSH that they have, it is sufficient for them to maintain the needs of antioxidant needs of the cell if they are at normal basal condition. No stress in the life. They're all happy, no issues, you are fine. G6PD deficiency patients, they lead absolutely normal life if they don't get into any stressful events where there will be increase in reactive oxygen species. If there is an increase in reactive oxygen species for whatever the reason, they need more GSH at that time because there are more reactive oxygen molecules, right? To fight against them, you need more GSH, but you don't have. At that time, these patients will get into trouble. Is it not? Marco, how many dollars you brought to Island for this semester? Just throw a random number. You don't need to tell how much it is. What? $100 for 4 months? Come on, man. 4 months, $100. Okay, that's a random number. I'll take it. Okay, $100. If he doesn't go to party, no excess buying, no excess drinking, just being conservative, knowing that I have only $100, is being careful. No problem. He will survive this semester. Suddenly, he start going to party, paying bills. What happens? He'll be in trouble. That's exactly what happens with G6PD deficiency patient. They have limited number of GSH. They have to manage within that. That means they should not get into any infection. They should not take any medications. They should not take any chemicals, toxins, which will build up reactive oxygen species. Once that happens, then they will be in trouble. Okay. And these are the trouble that you need to know. Troubles for G6PD patients. I have written normally asymptomatic. Normally they are asymptomatic unless triggered. Unless triggered. So what is the triggering events? That will be given in the stem. Triggering events will be given in the stem. You got to identify them. Once you identify them, it is pentose phosphate pathway, G6PD. That's how. Okay. What are the triggering events? If the patient with G6PD deficiency, like African, Middle Eastern, South Asian, Mediterranean person, get into infection and then hemolytic anemia, then it is G6PD. Infection increases reactive oxygen species, or ingestion of anti-malarials, sulfonamides, analgesics, thiazosulfone, methylene blue, naphthalene, non-sulfa antibiotics. How do you remember them? Just remember drugs and chemicals. That's it. Drugs and chemicals. Any drugs and chemicals. Infections, drugs, chemicals, triggering events. That's it. Even if you don't go into details of all these drugs here, the class, sulfonamides, analgesics, antimalarials, and methylene blue, which is a chemical, naphthalene chemical. Now, any drugs and chemicals in general triggers G6PD deficiency patient because that generate reactive oxygen species. So you got to look for that in the stem. Patients presents with signs of anemia. There will be signs of anemia. I forgot to bold this part or put it in blue color. If you please make it a blue color. Patients presents with signs of anemia. What are the signs of anemia? I already explained you. Weakness, shortness of breath, pale skin, brittle nails, mouth ulcers, tachycardia because of low hemoglobin. So your heart has to work overtime to, supply oxygen to the tissues. Then jaundice, you know why? So bilirubin is increased. Hematuria, red blood cell breaking open, releasing hemoglobin. Hemoglobin can appear in the urine, leading to hematuria. And hematuria is blood in the urine. So these are a couple of things that you will see in G6PD deficiency patients. Then there is a concept called favism. What is favism here? Favism is, it is upon consumption of fava beans, you're going to see signs and symptoms in a G6PD deficient person. Favism is, it is seen in a patient who has got G6PD deficiency and they become symptomatic when they consume fava beans. That's what it is. Like say you and me, if we consume fava beans, we don't get into hemolytic anemia, considering that no one in this class has G6PD deficiency, right? We don't get into signs and symptoms even if we consume fava beans. So favism is, it is signs and symptoms that is seen in G6PD. Already they have G6PD deficiency, but they will become symptomatic upon consumption of fava beans. That is what is called as favism. Consumption of fava beans, common in Mediterranean countries. And what are the Mediterranean countries? I written here: Greece, Italy, Spain, Portugal, Turkey. These are the areas where like fava beans consumed on these people who have G6PD already, then they will become symptomatic. So that's why in one of our case stem that I have shown, the sample stem, it was written Italy, Mediterranean. Okay, so that's how you connect. So that is what is called favism. So symptoms include pallor, hemoglobin, basically signs of anemia you're going to see after 24 to 48 hours of ingestion of beans. Then G6PD deficiency protects patients from severe malaria. I have already explained you why. Why patients with in areas where malaria is endemic, why do you see G6PD deficiency? It is just to protect against a severe condition. It's a survival mechanism. Okay, so that is the reason. This type of disorders which are kind of evolved just to protect against severe condition, it is called as heterozygote advantage. Like heterozygote advantage in the sense, these are X-linked conditions, and females are protected because they have another X chromosome copy. They just act as carriers, whereas males are affected with the disorder, but the condition is okay compared to severe malaria. Okay, so that is what heterozygote advantage, this protection against malaria there. That is the concept. You just need to be aware what is the connection between malaria and G6PD. Just a survival advantage. Okay, that's it. Coming to how do you diagnose G6PD deficiency? You start with the family history. A couple of things that you should look for, especially in the laboratory thing, or like when you look at the case stem, look for family history. So males in the family affected. Males in the family affected. Because it is X-linked condition. It runs in the family, but only males are affected. Okay. What about pyruvate kinase, which is a close, differential diagnosis? Pyruvate kinase is both males and females affected. Okay, that's how you differentiate there. And then negative direct antiglobin test, that is Combs test. Combs test is negative. Remember, Combs test is for, this test is for antigen antibody reactions. Not sure in immunology this test is mentioned. Is it mentioned? No. Maybe in micro they might mention. I'll just put it in brief. Combs test is done to identify. Combs test is done to identify antigen antibody mediated hemolysis. If the hemolysis is antigen antibody mediated thing, then it will come positive. Combs test will be positive. Combs test is done to identify antigen antibody reactions. Okay, is G6PD is antigen antibody related hemolysis or nothing to do with antigen antibody? Nothing to do with antigen antibody, right? It's an enzyme deficiency disease. So obviously Combs test will be negative. Combs test, the purpose of Combs test is to identify antigen antibody mediated hemolytic anemia. This is a nothing to do with antigen antibody. That's why negative direct antiglobulin test or Combs test. If it is negative, why we are worried about that? Consider that you are in your clinic, your hospital. Patient comes and patient has signs of anemia. And you don't get that classic thing, family history and all that. But you need to diagnose this patient. What kind of anemia is this? How do you work on that? There are hundreds of causes for anemia. How do you know this is a G6PD deficiency anemia? In what direction you need to go? You got to begin somewhere, right? So there are two broad ways you can do. If you do Combs test, and if the Combs test comes positive, then you think about antigen antibody hemolytic anemias. You rule out all other enzyme things and other things are taken out. You are just working on one direction, antigen antibody. And that means you have ruled out so many disorders by just doing one test. If the Combs test comes negative, then you forget about antigen antibody hemolytic anemias, work on enzyme anemias. See, this is how it helps. Right now, you may not see that much importance to it. But when you are really in that situation, then you will understand. Okay. So this simply it will rule out things. Okay. Anyway, this may not be given, in most of the case times. The next one, which you should look for, is hinge bodies and bite cells. Hinge bodies and bite cells are also called as degmocytes. So hinge bodies these are precipitated hemoglobins that I have already explained you. This is a hemoglobin is kind of precipitated and present beneath the membrane, and which you can see in the microscope when you do the peripheral smear. Bite cells is what? Bite cells is that precipitated hemoglobin. When you look at under the microscope, it doesn't stain well, or you don't see it really well. Like it's not that characteristic. It looks like as if that part of the membrane is kind of bitten by somebody, right? I'll write a figure here. So consider, see, this is your red blood cell, and I'm going to make precipitated hemoglobin that is here, which is kind of beneath the membrane. This is hinge body, precipitated hemoglobin. The rest of the hemoglobin is soluble, which is not precipitated, means that's the hemoglobin is soluble. Remember, in the red blood cell, hemoglobin is soluble and it is part of your cytoplasm. You don't see any hemoglobin there. It's like your, when you take a blood sample, do you see red blood cells in the blood with the naked eye? It just looks red, that's it. You don't see red blood cell, platelets, all because they are soluble. Right? So like that in the red blood cell, within the red blood cell, hemoglobin is soluble. You don't see, you just see cytoplasm. Whereas the only that hemoglobin which is precipitated, you see kind of attached somewhere beneath the membrane. That's hinge body. Okay. So when you look at this particular type of red blood cell under microscope, right, that precipitated part, it doesn't appear clearly. Okay. It appears something like this. This portion it appears, okay, sorry, I'm going to rewrite that. So this particular portion, it appears something like this. You don't see that part. This part is kind of, you don't see clearly, that only that part. Okay. So how do you see that now? This is a biconcave shaped red blood cell. Only that portion, you don't see it clearly in the microscope. So it's as if that part is bitten, taken. You take a cookie and take one bite and then see. How do you see that cookie? That portion, you don't see it. In the same way, you take a bite out of your red blood cell. Only the portion where hinge body was there, you take a bite. You means, just saying. So whatever the left, that portion which you don't see, that is called as bite cell. See the bite cell. Somebody is bitten. You got the idea? Okay. That is why it is called bite cells, which are called agmocytes, which is characteristic of G6PD deficiency. Make sure you remember that. I put it in blue color. All right, that will give you answer for G6PD. Low hemoglobin, which you understand, microcytic hypochromic anemia. What is the meaning of microcytic hypochromic anemia? Microcytic red blood cells are small in size, hypochromia, less coloration. Why? Because hemoglobin is less. Less hemoglobin makes red blood cells smaller in size and also color pale. Microcytic hypochromic anemia, characteristic of any hemolytic anemia for that matter. Negative Butler fluorescent spot test indicative of low red blood cell NADPH levels. Spectrophotometric analysis of G6PD activity, decreased NADPH activity can be seen here. Overall, in this, whatever I have written here, give importance to family history. Males in the family affected, indicating X-linked condition. And then hinge bodies and bite cells. And of course, signs of anemia. And then look for what is the triggering event. Okay, triggering event. So let me write down all of them. Clues. Triggering event can be infection, drugs, chemicals. Okay, that's one. And then family history. Family history, males in the family affected. Okay, and then signs of anemia. Signs of anemia. And the third one, hinge bodies, bite cells. Okay, so if you have all these things, so you cannot go wrong with G6PD deficiency. That's it. Okay, so if you look at all these things, then your answer will be decrease in G6PD, decrease in NADPH, decrease in NADPH, decrease in GSH, decrease in glutathione peroxidase, decrease in glutathione reductase, increase in H2O2, increase in GSSG, oxidized glutathione. Okay. And then because of all these things, there will be increase in RBC, membrane peroxidation. That's it. I have given everything to you. I am not hiding anything. These are the things. This is what will be asked. Whoever makes question, if you know this, you cannot miss the answer. These are the areas where choices, these are the choices that I have given. All the correct choices with G6PD. This is what it is. How many correct choices I have given? 1, 2, 3, 4, 5, 6, and then 7, 8. That means 8 questions. You know now. Because 8 choices, 8 correct choices means 8 possible ways of asking questions. Okay. So make sure you go to the correct answer in the block exam. Those who don't, I will call you. Tell what's wrong with you. That's it. Okay. This is as easy as it is. All right. Any question, any doubt? This is what is all about G6PD deficiency. All right. Let's do a question. Let's test how much you understood. Okay, so 23-year-old man. Okay, and then Italian origin, Mediterranean. Comes to physician because of 5-day history of fatigue and shortness of breath. That's anemia. Recently had urinary tract infection. See, there's infection. And then the patient has taken the drug, trimethoprim sulfamethoxazole. That's a sulfur drug. Physical examination has shown pallor, that is sign of anemia. Scleral icterus, jaundice. Laboratory signs show hematocrit 38%, which is lower than normal. That's indicative of hemoglobin being decreased. MCV, the size of the red blood cell, mean corpuscular volume, MCV, 83, which is kind of lower range of normal red blood cell size. That means it is going towards microcytic hypochromic type, right? Indirect bilirubin concentration is 4.8 milligram. That is high. Bilirubin increased. So all these things will should make you to go towards G6PD deficiency. Okay. So, but what is asked is not the enzyme which is deficient. See, enzyme name not given. The question is, what's going on here? Failure. What is the effect of G6PD deficiency? That means low NADPH, low GSH, low antioxidant means red blood cell membrane peroxidation. Red blood cell is not protected. So erythrocyte erythrocyte protection against membrane oxidation is the one that is kind of affected here in this patient. So most likely due to the failure of which of the following. So failure to protect red blood cells. That should be your answer. Okay, that's how we will go towards answer. Redness, swelling in his mouth, diarrhea, vomiting, pains in his chest upon inhalation, physical examination, swollen lymph nodes in the neck and fever. History reveals patient had frequent bouts of infection. Physician suspects a particular disorder and orders a DHR test, dihydrorhodamine, for confirmation. Assuming the physician is correct in his diagnosis, a defect in which of the following would most likely contribute to pathology in this patient? So what is the condition that you are looking for in the stem? Chronic granulomatous disorder. I told you, whenever you come across DHR, dihydrorhodamine, or NBT, nitrobutyrolonium, think about CGD, chronic granulomatous disorder, and then think about NADPH oxidase, NADPH, respiratory burst, pentose phosphate pathway, G6PD deficiency. So G6PD deficiency can put somebody at this particular thing. So which are the following most likely contribute to the pathology in this patient? It is G6PD, glucose 6-phosphate dehydrogenase defect. Okay, let's go to the next one. So that increase, decrease, all that will come here. So this is a case of, see, there is a fava beans and Hinge bodies. So you know the diagnosis, that is G6PD deficiency. Okay, favism. So knowing that it is a G6PD deficiency, see what they have asked is additional finding. So additional finding is they will have decreased glutathione concentration, reduced glutathione concentration. If these choices were something like this, if I made this question, right, in all these places, I'm going to say, okay, increased NADPH. These are my choices. Decrease GSH, increase GSSG, not increase, let's say decrease GSSG, and then increased glutathione peroxidase activity, increased glutathione reductase activity. Okay, what is your answer? Answer is, see how you are getting confused now. The answer is still B, is it not? What is decreased? Decreased is GSH is decreased. Your antioxidant is decreased, is it not? In G6PD deficiency, antioxidant is decreased. That is GSH is decreased, reduced GSH, reduced glutathione decreased. And if the reduced glutathione is decreased, why it is decreased? Because NADPH is decreased. Why? Because G6PD is decreased, NADPH is decreased. So here I have written increase in NADPH. It should not be increased. It is decreased. That should not be your answer. And then when GSH is decreased, what will happen to GSSG? Will increase, but I written decrease GSSG. It should not be the answer. Actually, it is increased, right? And then what happens to the glutathione peroxidase activity? Decreases. I have written increase, which is wrong. So, and then what happens to glutathione reductase activity? Decreases. Decrease normal in that patient, but I have written increase. Basically, I just written opposite of what is seen, except GSH, which is correct. So like this, examiners will try to confuse you. That's how we do. You should not get confused. That is how it is. Okay? This is how things are used. So why this you got confused? Because all of these choices are connected, what I have written. Whereas in this question, choices, how many things are connected to your stem? It was B and D. Other choices have nothing to do with this pentose phosphate pathway. That's why you had little less confusion. Okay, when all choices are connected, then you get confused. So, but if you know the concept correctly, you will go to the correct answer. You may not see all of them connected in the choices, but I'm just giving you the hardest one.